as we get. So I'm gonna leave the stage to you.
Shelly, for the introduction. Can you see my face? Because I accidentally closed out my self view.
Let me see. I don't. There you are.
Yes, there's me. Find me. Okay, great. So hi everybody. As Shelly said, I'm Marielle. Shelly is my mentor. She's the best one in the program, so I got lucky there. I will be covering electrolyte emergencies. Next. So these are the topics I'll be covering. Sodium, that's going to be definitely the meatiest portion of the talk. Potassium, calcium, magnesium, and phosphate. Next. So for sodium, I hope you all get comfortable with whatever your position you're in, where you're sitting, because this one is definitely going to be the biggest, most important part of the lecture. So I'm going to do an overview. We're going to go through some general principles about sodium. We're going to talk about fluids and sodium, and then I'll cover hyponatremia and hypernatremia. So for an overview, this is the most important extracellular cation. It's really important in maintaining the body's extracellular fluid volume. A sodium imbalance, dilution or concentration of extracellular fluid rather than gain or loss of sodium, which is antidiuretic hormone or vasopressin. I'm not sure which one, which term you prefer for it in your country. Usually here we say ADH. It can also be the direct result of sodium loss, GI losses, vomiting or diarrhea, diuretics, or an intake, lack of intake. So for the treatment, you ideally treat the underlying cause, and then you gradually and very carefully correct the sodium. So general principles. This is the normal sodium. It's 135 to 145. Depending on what lab you use or what reference you're using, it can vary a little bit between like 132 to 142, things like that. But just have a general idea. So for hyponatremia, for the most part, it's largely secondary to the intake of water that is not excreted. So your body is holding on to water. For hypernatremia, this is due to the loss of water. When someone says that the person is hypovolemic and hyponatremic, this means that you're losing sodium and water, both of them. When someone is edematous, like with CHF or congestive heart failure, it's due to the retention of sodium and water. So I don't know about you, but the fluid sodium, the fluid compartments and these, rectangles weren't super exciting to me. But as I've been practicing and, giving people normal saline left and right, I realized it's super important to actually understand the behavior of whatever fluid you're giving your patient, like where it's going to go in the body. Otherwise, you really shouldn't be giving your patients fluids if you don't know what the body's going to do to it. So for the total body water, there's two compartments. They're separated by the cell membrane. The extracellular fluid is the plasma fluid, like in the vasculature, as well as the interstitial fluid, which is in the parenchyma. Intracellular fluid is, as it says, it's inside the cells. So the cell membrane is freely permeable to water, but not to electrolytes. It maintains the composition of different solutes in the extracellular fluid and the intracellular fluid. So in the ECF, there's sodium salts, bicarb and chloride primarily, and in the ICF, there's potassium salts and macromolecular organic phosphates. Next. So this is the normal total body water distribution up here. So like I said, the extracellular fluid is the interstitial and the plasma, and the intracellular fluid is in the cells. So that's about 2/3 of the total body water, and the ECF is about 1/3. So I have a question here. We might have to go back to the screen, the original screen. Can we go back?
Thank God it's frozen. Sorry. Hold on, why is it going?
Oh, oops.
No one saw that.
So take a look at the dotted lines on the outside. For 1, 2, and 3, we have added a mystery fluid to each one. So to one of them, we added just free water. To one of them, we added just salt. And to one of them, we added isotonic fluid. So what did we add to 1, 2, and 3?
So take a look, and then I'll put the poll up. Okay, so your options: saline, water, or salt. Those are the 3 options. So 1 went into 1, 1 went into 2, 1 went into 3. So now hopefully you figured out what you want to answer. And people were cheating.
They're just using their resources. I mean, it's
Technical difficulties. I needed at least 1 today.
My bad. Okay. Yeah,
No, it's actually fine.
So for one of the dotted lines expanded both the ECF and the ICF. That's free water. It goes into both compartments, and it'll equalize. For 2, we added isotonic saline. So once it ends up in the ECF, it's happy there. It's not going to move because it's isotonic to it. And then for 3, we just added salt. It kind of expands the extracellular fluid, and then it takes water from the ICF. Next. There you go. Okay. So fluids and sodium, the extracellular fluid volume. In adults, the extracellular fluid volume is about 33% of the total body water, which I mentioned earlier. It's regulated by the kidneys, the renin, angiotensin, aldosterone, that pathway, everyone's favorite to learn about, and the natriuretic peptides, so BNP and ANP. The intracellular fluid volume is about 2/3 of the total body water. Next. So I just wanted to go over the effective arterial blood volume. It's really important to understand, especially in cases of congestive heart failure or cirrhosis. So pressure is the trigger for hormone regulators of ECF volume. The changes are sensed by 3 major pressure receptors. In the JG cells in the kidneys, they sense renal perfusion pressure. They synthesize and secrete renin, which activates the rest of the RAAS. The carotid sinus and aortic receptors regulate sympathetic nervous system, and cardiac receptors are activated and lead to the release of ANP and BNP. ANP is in the atria, and BNP is not in the B, it's not in the brain, it's actually in the ventricles. Next. So the effective arterial blood volume, again, just more comments on that. The pressure is the trigger, as we said. CHF and edema and cirrhosis and ascites are very important, I guess, conditions that you're going to see a lot of in your patients, no matter for most specialties, really. The increased ECF volume, but it's decreased effective arterial blood volume. You get decreased perfusion pressure, and it activates the renin, angiotensin, aldosterone system. The fluid doesn't stay intravascular due to disease pathology. You get a decreased cardiac output in most cases of CHF. The fluid backs up, it doesn't stay intravascular, so the kidneys think that there's not enough fluid in the body, but there's actually a ton of fluid in the body, it's just not where you want it. And in cirrhosis, you get a huge vasodilation component, so again, the kidneys feel like they're not being perfused properly. Next. So I have a big star here next to this equation, the plasma osmolality. I have a big star there because if you haven't memorized it already for any of your board exams, whatever your version is in your country, or if you take USMLE, you should memorize it. It will come up a lot. So normal plasma osmolality is 275 to 290 milliosmoles per kilogram. I have 2 equations here because the one on the top is what we use in the States. Usually the BUN is reported in milligrams per deciliter. Other places outside the United States more commonly use the bottom one, and I think it looks nicer because it's only 2 times the sodium concentration times the glucose concentration, or plus the glucose concentration plus the urea concentration. But yeah, I think you should memorize it. It's a very important equation, and it'll come up a lot. Next. So the effective plasma osmolality. You'll notice that it looks pretty similar to the plasma osmolality equation, but it doesn't include BUN. So this reflects the concentration of solutes that don't easily cross the cell membranes. So they stay in their compartments, and these stay in their compartments, the sodium and the glucose, and affect the movement of water. Urea is not there because it doesn't freely cross the membrane. It's called an ineffective osmo, except in the special scenario of dialysis where basically just a ton of urea all at once will act like an osmo, but for the most part, it does not. Okay, next. So what's the difference between dehydration and hypovolemia? I think this is important to point out because sometimes in my head, I think the two are the same, but they're actually a little different. So for dehydration, there's a reduction in total body water below the normal level without a proportional reduction in sodium and potassium. It's what it says, it's dehydration, just free water loss, basically. It leads to hypernatremia. Water from the cells equilibrates out of the cells and into the extracellular fluid, so the effective arterial blood volume is preserved. This happens with insensible losses like sweat or in the respiratory tract, and in diabetes insipidus, where the patient is just excreting free water. In hypovolemia, the extracellular volume is reduced. You get a loss of water and salt. So this can happen with vomiting, diarrhea, and diuretics. Next. So hyponatremia. This is the big one usually. We're going to go over the classification, symptoms, the workup in the labs, emergent treatment, and the overcorrection, which is the big dreaded issue when you're correcting hyponatremia, and how to fix it. So you have probably seen this before. This is basically how to categorize or think about hyponatremia. In real life, it's a little hard to categorize your patients in just one, but for the test purposes, usually they're categorized pretty well, and it'll be obvious, and we'll go over that a little bit. So if a patient is hyponatremic, you took their labs, their sodium is low. Measure the serum osmolality with the equations that we just went over. So if they're hyperosmolar and hyponatremic, it's called hypertonic hyponatremia. The most common example of this will be with hyperglycemia, because glucose is staying in the ECF. It's pulling out it's pulling out water, and then the sodium concentration is getting diluted. But there's technically possibly a normal amount of sodium there. It's just diluted from the water. You'll also see that with other things like mannitol, maltose, glycerol, and glycine. For isoosmolar, if they're isoosmolar, this is considered pseudo-hyponatremia. This is actually more of a lab error that doesn't happen as much, but it will depend on your lab and how they process the sample. This will happen if the patient has hyperlipidemia or hyperproteinemia. This can actually also happen post-op with, they use an irrigation solution with glycine, sorbitol, or mannitol. Not as common, but it does happen, and something to keep in mind if you have a post-op patient. If it's hypoosmolar, this is considered, true hyponatremia, because there really is essentially less sodium. If they're hyperosmolar, then you have to assess the volume status. Next. Okay, so the patient truly has less sodium. They are hypoosmolar and they're hyponatremic. What is their volume status? This is where it can get tricky in real life, because kind of differentiating between euvolemic or hypervolemic and hypo, sometimes it's a little tough. Hypervolemic is a little more obvious because there'll be edematous. The other two, not so much necessarily. But for hypovolemic hyponatremia, it's divided into renal causes and into extrarenal causes. For renal causes, again, diuretics, mineralocorticoid deficiency, salt-losing nephropathy, or cerebral salt wasting. For extrarenal causes, there's vomiting, diarrhea, burns, trauma, and pancreatitis. For euvolemic hyponatremia, we have psychogenic polydipsia, Addison's, which is the glucocorticoid deficiency, RTA, renal tubular acidosis, thyroid, it's hypothyroid, but for the sake of the mnemonic, we just call it thyroid, and remember it's low. and syndrome of inappropriate antidiuretic hormone. And a mnemonic I noticed for that is PARTS. You can change it if you want. It can say strap, it can say STARP, which is not a real word, but if you choose to remember it like that, that's fine. And then for hypovolemic hyponatremia, this is the congestive heart failure, cirrhosis, nephrotic syndrome, acute kidney injury, and chronic kidney disease. We don't have to go through the bottom as much, but you can tell if someone's underfilled, if there's orthostatic blood pressure changes. Again, if they're underfilled, and if they're overfilled, there'll be edema. You can look at the urine osmolality if you want, but in the interest of time, we don't have to. So we can go next. So for diagnosis, it's based on the lab value. We measure the sodium, the electrolytes. Consider repeating it if the value doesn't match what's going on in front of you. If the patient seems totally fine and for some reason their sodium's 120 and they're otherwise healthy, it's probably not right. If the other electrolytes are also abnormal, consider repeating it. And then another issue that can cause pseudo hyponatremia is if the patient has isotonic or hypotonic rather infusions going, and then they have another IV downstream of that, and that's where the sample was taken. So it can be diluted falsely. So what are some symptoms of hyponatremia?
Did I make this an open-ended one? I think I did.
I think so.
Oh. I even forgot what I put in here. PowerPoint. There's been so many. So guys, if you go to the link, you could actually type in your responses and you could see them come up live. Oh, there we go. It worked.
Good.
This is the first one using an open-ended one, by the way.
Oh, fancy. Yes.
Lots of confusion, dizziness, nausea. Awesome. Ooh. Okay, got her out there. That was really good.
Yep.
Awesome.
Okay. Oops. Okay. So yeah, you guys got it. Basically, neurological symptoms. It's an issue of cerebral edema from the hyponatremia. And possibly to the adaptations of the brain to the swelling. So hyponatremia promotes the movement of water from plasma and CSF into the brain. So it swells, and that's not good. We don't like that. It's related to how quickly the hyponatremia develops as well, and of course the severity. Cerebral edema occurs primarily with a really quick reduction in the sodium concentration, usually within 24 hours. Normally, you will see this in primary polydipsia. Classically, in a test question, it'll be a psych patient who is just drinking tons and tons of water. You can also get exercise-associated hyponatremia, where the patient is drinking a ton of water to stay hydrated, and they're actually also diluting their sodium. Next. So what are the symptoms of hyponatremia? You guys nailed it. So some of the symptoms are also due to the adaptation of the brain to swelling. It's kind of a balance between the swelling and how well the brain adapted to it. So at first, the swelling leads to increased intracranial pressure, and then it leads to neurological symptoms. But after 48 hours, the brain cells begin to adapt. They spit out sodium, potassium, chloride, glycine, and taurine, which are all osmotically active. By doing this, the osmolality is decreased in the cell, so you get water movement out. Conditions where this mechanism is compromised would be in SIADH, in children, and in hypoxia. So the symptoms of hyponatremia can also be due to other conditions. Consider other etiologies when deciding on treatment. So one example of this would be uncontrolled diabetes. The serum osmolality is elevated. That's because they have so much glucose floating around. There's an increase in the effective serum osmolality, so water is pulled out of the cells and the sodium is diluted. In this case, hyponatremia is not the cause of the symptoms because the affected plasma osmolality is actually increased. So it wouldn't really be causing edema in the brain. So the symptoms. You guys nailed it again. Headache, nausea, vomiting, disorientation, confusion, gait instability, areflexia. And the most severe, most dramatic are seizure and coma. You can also get neurogenic pulmonary edema. Some risk factors that make you more at risk for severe symptoms of hyponatremia are if it's acute, if it happens really fast. Apparently, premenopausal women have less extra space in their intracranial cavity, so they're more at risk for having severe brain swelling. If you have a space-occupying lesion, that's also an issue, or if you have a known seizure disorder. Just one note about the categorization of moderately severe versus severe. Depending on the text, you'll hear mild symptoms versus severe. You'll hear less severe versus severe. Just know that all symptoms from hyponatremia are neurological. If they're having a seizure or they're comatose, that's severe. Everything else is still bad, and it should be treated right away. So go next. So neurogenic pulmonary edema, I just wanted to include this because I hadn't personally read about it. I thought it was interesting. It's the acute onset of pulmonary edema after a significant central nervous system insult. Conditions that cause abrupt and extreme increase in intracranial pressure are at the highest risk of being associated with neurogenic pulmonary edema. One of them being hyponatremia and the subsequent swelling. So the compression of the brain and the damage or ischemia is thought to lead to increase of catecholamines. This leads to systemic vasoconstriction, and then the blood pools in the pulmonary circulation. And then you get an increase in hydrostatic pressure, and then you get pulmonary edema. This is, yeah, okay, that's fine. No, that's just a picture of it. That's all. Next. So what labs? You'll notice a pattern here for all these electrolytes. Obviously, you measure the electrolytes, including calcium, magnesium phosphate, also glucose. And then you measure the serum osmolality. If it's normal or increased, that is pseudo hyponatremia. It's not true hyponatremia. You'll also want to get TSH because, as I mentioned earlier, hypothyroidism can cause hyponatremia, and then cortisol because Addison's disease can also cause hyponatremia. So the urine osmolality and specific gravity. This can tell you a little bit about the etiology of the hyponatremia. If the urine is really concentrated, i.e. the urine osmolality is over 300 milliosms, or the specific gravity is greater than 1.01. This will likely be the case in most hyponatremic patients. Non-specific doesn't point to a specific etiology, but it does indicate that the kidney is holding onto water, which is not what you want them to do if they're hyponatremic. You want them to get rid of water to concentrate the sodium. So giving isotonic fluid in this case may actually make the hyponatremia worse. The kidneys aren't behaving the way you want them to. So if they see normal saline, they might just hold onto the water and then excrete the sodium. We don't want that. So if the urine is dilute, you can see a urine osmolality of significantly less than 300 or specific gravity of less than 1.01. This means that the kidney is getting rid of water. You want it to do that. It implies that the hyponatremia is secondary to an increased water intake relative to solute intake, or the patient is in the recovery phase of hyponatremia and they're autocorrecting. A dilute urine will lead to an increase in sodium, and that is the direction we want to go in. Large volumes of dilute urine may actually indicate that the sodium may overcorrect in the near future. So if you have a lower urine sodium, less than 20 milliequivalents per liter, could indicate hypovolemic hyponatremia due to extrarenal losses. Overall, it indicates a loss of sodium, so there's less in the plasma and less in the urine. There's just less sodium all around. If it's hypervolemic hyponatremia, like in heart failure or cirrhosis, there'll be less sodium. This means that there's less sodium in the urine because the kidneys are holding on to it. They're just trying to increase the effective arterial blood volume. If the urine sodium is intermediate, between 20 to 40, it's not really helpful, and just disregard that. If the urine sodium is higher, greater than 40, in euvolemic hyponatremia, it kind of tells you that the kidneys are holding onto water, leaving a higher concentration of sodium in the urine. It can also tell you about hypovolemic hyponatremia due to renal salt wasting, because obviously it's getting rid of the sodium in the urine. So the initial management of hyponatremia. It is the same regardless of the cause. If it's CHF, if it's SIADH, if they're symptomatic and the sodium is really low, you need to treat it. Initial management in the ED will be the same. So you want to start off by sending the labs, which we went through, but don't wait for them to come back before starting treatment. You're going to want to stop free water intake immediately, including isotonic saline, because as I went over earlier, that actually can make hyponatremia worse. An indication for hypertonic therapy is any kind of symptomatic hyponatremia, regardless of if it's nausea or if they're seizing. You still want to give them hypertonic saline. So on the right, this is from a website. It's called the Internet Book of Critical Care. It's really useful. You'll see a lot of other graphics from this in my talk. So if you want to refer to that later on, I have the link in the bottom left of this slide. So the initial package for critical hyponatremia, like we said, order a lab panel, prevent further water intake, and then if they're symptomatic, give them IV hypertonic therapy. And then there are two different options that I'll go over. So I went with this one first because I thought it was pretty interesting. And in the ED, hypertonic bicarb is actually more readily available than hypertonic saline, though hypertonic saline is the classic go-to. So these are the ampules that are in the crash carts. The box might look like this on the right. It's easy and fast to obtain in an emergency because if we're in the emergency department, we all know where the crash carts are and we can access them. So 1 milliequivalent per milliliter of sodium bicarb has the same tonicity as 6% sodium chloride. So if you give 2 amps, which is approximately 200 mLs of 3% normal saline, it will raise the sodium by about 3 millimolars. So 2 boxes will increase by 3, if you just think about it like that. So you want to infuse it slowly, 1 over 5 to 10 minutes. And this is obviously contraindicated in patients with metabolic alkalosis. If they're already alkalotic, you do not want to give them more bicarb. Next. So here is the classic hypertonic saline. It's traditional. The issue is that you may have to wait for it to be sent from pharmacy, whereas you're probably standing right next to a crash cart in the emergency department. But this is fine too. Our pharmacies, they're pretty quick. So it's 2 mLs per kilogram body weight. This equates to, in the classic 70 kilogram patient, about 150 mLs of normal saline. And you can administer it through a peripheral line. Some sources say you can't. But if you want to go to the EM Crit site that I cited, they will give you multiple resources saying that it is safe. So the target rate. Acutely, if the patient is symptomatic, the goal is to increase it by 3 to 5 millimoles. I have a star next to these because these are good numbers to have memorized. Even just by having it raised by 3 to 5, you should see an improvement of symptoms. If, for example, the patient's at 120 and you raise it to 123 is still very low, but you should still see an improvement. After you give them hypertonic therapy, it's important to repeat a full electrolyte panel. So the goal in a 24-hour period would be to increase the sodium by 6 and no more than 8. Absolutely do not go over 8. This includes whatever, however much was given in the acute setting. So if down in the ED, they raised it by 5, you need to include this in that range. So then if you're on the floor, you can only go by 1 more or just keep it the same. If the sodium, this is basically what I said. If the sodium was increased by 6 to treat symptomatic hypernatremia, then over 24 hours, maintain that level of sodium. Next. So the overcorrection, this is the dreaded osmotic demyelination syndrome or central pontine myelinolysis. People are kind of moving away from that name because yes, it affects the pons, but it affects the rest of the brain too. So this is from severe damage of the myelin sheath, the brainstem especially, hence the pontine part. You'll get dysarthria, dysphagia, paralysis, and locked-in syndrome, which personally is a nightmare of mine, where if you're not familiar with it, all the voluntary skeletal muscles in your body are paralyzed. You cannot move them, but you're still conscious. Like you're in there, you can think, you can process what's going on around you. And if you're lucky, maybe you can move your eyes and blink, but that's it. So some common causes of overcorrection is actually not giving, it's actually not from giving the patient hypertonic saline. For the most part, it's because the underlying cause has been reversed. So the patient is autocorrecting, or something like giving the patient potassium chloride. So if they also have a concomitant hypokalemia, which I'll also go over later, if you give them KCl, you have to understand that this is actually kind of equal to giving them sodium. So if you give them KCl, potassium goes into the cell. But if we recall the ATPase, it will pump 2 potassium into the cell, but it pumps 3 sodium out. So this will also cause an overcorrection of hyponatremia. You'll also see this if someone uses Vaptans to treat hyponatremia. This leads to uncontrolled diabetes insipidus. Basically, do not use Vaptans across the board. It's a no-no. You don't know how much water the patient is going to excrete. And just to track back, Vaptans are vasopressin receptor inhibitors. So just don't use that in hyponatremia. It's very unpredictable, and it's bad. It's not going to be the answer on an exam either. Next. So risk factors for osmotic demyelination. If the patient has really severe hyponatremia or it's chronic hyponatremia, if it's chronic and you correct it really quickly, you're at a risk for this. If it's greater than an 8 to 10 rise per day in cirrhotics or alcoholics, if there's malnutrition or if there's hypokalemia. Next. So how do we correct an overcorrection? I feel like a lot of my resources never really talked about this, and I thought it's pretty important to go over. If you have a hyponatremic patient, you realize that you corrected it by more than 6 to 8 in a day, don't panic. You can treat it, and as long as the sodium is lowered immediately, the patient will be okay. Osmotic demyelination doesn't occur immediately, but if you see that it happens, the patient seems fine, do not leave it like that. They may develop symptoms later down the road, so it's important to correct it right away. And now we will go over how to correct it. Again, this is another figure from EM-Crit, the Internet Book of Critical Care. This is something called the DDAVP clamp. It prevents the kidneys from secreting free water. This is basically antidiuretic hormone, vasopressin. It clamps the kidneys because it kind of takes them out of the equation. You know, whatever water or fluid you give that patient, they're going to hold on to it. So it makes the way the fluid behaves in the patient more predictable. So if you give them hypotonic fluid, you know the sodium will decrease. The kidneys are not going to get rid of any water in that hypotonic fluid. So it's going to stay and it's going to decrease the sodium. If you give them hypertonic fluid, the sodium will increase. If you don't give them anything, which sometimes you want, if you want to keep the sodium level at the same value, then don't give the patient anything. Don't give them any kind of fluid and it'll stay the same. So the dose is 2 micrograms IV every 8 hours. Next. So here is a question. You are on your ICU rotation and managing a patient who presented with headache and confusion. His serum sodium concentration in the emergency department went out to be 120 milliequivalents per liter. He was given 2 amps of sodium bicarb. His symptoms improved. Repeat sodium is 123, and he is admitted to the ICU for further management. That same night, his sodium concentration is found to be 130. The patient is awake, alert, and oriented ×3 without any focal neurological deficits. He's grumpy that you woke him up. What do you do?
All right, guys, the poll is open. Let me just give the link in case you guys don't have it. All right, we're starting to get some answers. I like the Collier Senior.
That would have been me. That was me yesterday with one of my patients, and not gonna lie.
It all happens to us, I promise. It all happens. All right, we're getting some pretty good answers so far.
Yeah, this is going to be a good discussion. So yeah, why don't we talk about this? So the answer is actually lower the sodium to 126 to 128. So the patient looks fine now. 130 is his sodium, and that's a normal level, but he started off at 120, and that means that his sodium increased by 10 in one day, which puts him at risk for osmotic demyelination. So even though he looks fine, you're going to want to lower it so that he doesn't down the line develop any symptoms like locked-in syndrome. Okay, so some key points. There's many causes of hyponatremia. If it's symptomatic, regardless of the cause, it's bad. Treat it with hypertonic saline or hypertonic bicarb. Correcting it by 3 to 5 should yield clinical improvement. And this needs to be factored into the overall 6 to 8 in a day goal. Osmotic demyelination is dangerous, but it can be avoided if the sodium is quickly relowered. Next. So hypernatremia. I'm gonna have to go fast. Okay. Causes, symptoms, yeah. Okay, causes, inadequate free water intake, GI loss. GI losses can make your electrolytes just all over the place and could cause any of these electrolyte abnormalities. Renal, hypertonic saline administration, ingestions of large amounts of salt, which patients do, and not so much now, but an infusion of saline into the uterine vein during a therapeutic abortion is a historic cause of this. Okay, next. Again, neurological symptoms, you know the drill with that. The reduction in brain volume can also lead to a rupture of cerebral veins. Severe symptoms occur with an acute elevation of sodium greater than 158. Greater than 180 has a very high mortality rate. The adaptations are the opposite of hyponatremia. So the brain cells uptake active osmolytes so that water will move into the brain. So for the labs, basically the same, the sodium, osmolality, the hematocrit. This is also, it could also potentially establish the diagnosis of diabetes insipidus. So the normal response to hypernatremia is to conserve water if the urine should be concentrated. If the urine is not concentrated, then that indicates diabetes insipidus because they're excreting free water when they should be holding on to it. Next. Free water deficit, this is the amount of free water loss responsible for hypernatremia. I don't think you need to memorize. If you don't have this app already, it's called M.B.S. It has basically every equation you can possibly think of. So chronic hypernatremia. This is if it's greater than 48 hours, you give them 5% dextrose in water, 1.35 mLs per kg per hour. In a 70 kilogram patient, that's 100 mLs, which is a nice number that you can memorize. Lower it by approximately 10 to 12 in a 24-hour period. In acute hypernatremia in 48 hours, again, 5% dextrose, which is 3 to 6 mLs per kg per hour. You can also use half normal saline. You need to check the sodium and blood glucose every 2 to 3 hours until the sodium is below 145. Then you can give an infusion rate until the serum sodium is 140. Basically, the goal is to lower it back to normal within 24 hours. This is much more forgiving than with acute hyponatremia correction. If the salt load is known to be lethal and ingestion has been in less than 6 hours, you can actually replace the deficit over 1 to 2 hours, which is very quick compared to hyponatremia. If the patient can tolerate oral, if the patient can tolerate oral, replace 2/3 of the free water loss with the equation I just mentioned orally, and then 1/3 IV. Okay, so hypovolemic hypernatremia. Fluid resuscitate first with isotonic saline, then correct their free water deficit. If they're euvolemic, just correct the free water deficit. If it's hypervolemic hypernatremia, give them a loop diuretic and then 5% dextrose. So the treatment, if it's central DI, the treatment is DDAVP 2 micrograms IV for every 8 hours, which is the same exact dose from if we're doing the DDAVP clamp for hyponatremia. If it's nephrogenic diabetes insipidus, just keep up with increased free water requirements. Thiazides may help by causing mild hypovolemia so that you get water reabsorption. So key points, overcorrecting or correcting hypernatremia involves correcting the free water deficit. Just know that the free water deficit equation exists. Use the internet or your phone. Correct chronic hypernatremia with a goal of 10 to 12 per day. Acute hypernatremia can be corrected a lot faster. Next. So potassium, okay. Normal potassium is 3.5 to 5.5. Again, values will vary a little bit, but this is the general range. It's a major intracellular cation. The normal concentration in the cell is about 150, excreted predominantly by the kidneys. Extracellular potassium is about 2% of the total body potassium. Acid-base imbalance in critically ill patients. Potassium has a very critical role in this. For every 0.1 decrease in pH, you can expect the potassium concentration to rise by about 0.6 due to potassium and hydrogen ion exchange. And hypokalemia. So this is a great chart, again, from that same website that I've been stating. The symptoms for hypokalemia, if it's mild, like 3 to 3.5, there's really no symptoms. If it's moderate, you can get intestinal smooth muscle dysfunction. It can cause ileus. This is really not ideal in post-op patients. With severe hypokalemia, you can get muscle cramps, weakness, arrhythmias, heart failure, and rhabdo. Next. So some of the causes, there's a ton, insufficient dietary intake, intracellular shifts like insulin, beta-2 agonist. These are actually some of the treatments for hyperkalemia, so they lower the potassium. Again, GI losses and renal losses, sweat, and hypomagnesemia. I have that in green because magnesium is super important to correct when you have any kind of electrolyte imbalance. Next. Workup and diagnosis, it's the same. Check the electrolytes. Magnesium is important. You have to fix that before you fix other things. Next. So EKG changes. With hypokalemia, you'll usually see EKG changes at less than 2.7. You'll see an increased amplitude of the P wave, PR prolongation, T wave flattening, ST depression, and U waves. Next. And Torsades point. This is very bad in a patient. You can see this in hypokalemia. You're going to want to go with magnesium too. So formulations, there's KCl, potassium chloride, which I mentioned earlier. This is the most commonly used. It's great for patients with metabolic alkalosis because the potassium will get exchanged for hydrogen ion. Potassium citrate is an option. It might be useful for non-anion gap metabolic acidosis because the citrate gets converted to bicarb. Next. For mild hypokalemia, you can replace it orally, give them foods or supplements. This is preferred because it's cheaper, it doesn't irritate your veins, and it's safer. If you have moderate hypokalemia or they're symptomatic, or it's really severe, PO is not an option. You have to replace it IV. Keep them on a cardiac monitor because replacing potassium and getting hyperkalemia is very dangerous. The typical rate of infusion is 10 milliequivalents per hour for routine repletion or 20 milliequivalents per hour for severe hypokalemia or DKA. For that, you need to use a central line or 2 peripheral lines. Target potassium level varies. Most you want to keep it greater than 3.5, and severe renal failure greater than 3, and DKA, you want to keep it a little higher at 5.3. So this is just a checklist, basically what we went over. Again, go to that website. It's great. You can go over it yourself too to review if you want. So key points in hypokalemia: look for EKG changes, keep them on a monitor. Aggressively replace magnesium. It prevents arrhythmias and it's safer than overcorrecting the potassium. Don't administer potassium in glucose-containing solutions to prevent insulin-induced potassium transfer into cells. Also, it's important to watch for hypokalemia in DKA patients because you're giving them insulin, which lowers potassium. So hyperkalemia. Here's a question. You obtain basic labs on a patient who is otherwise healthy with no past medical history and they're not taking any medications. EKG shows a normal sinus rhythm. Their potassium is high, it's at 6.5. What do you do? Okay, good. Okay, so the answer is B. C is technically not wrong because if it is truly 6.5, you don't want to wait around for the redraw results to come back. Okay, next. So the clinical issues with high potassium arise from problems with membrane polarization. Cardiac manifestations are the most serious. It messes up the resting membrane potential, and the cell is like partially depolarized. It's very excitable. Next. You get weakness, paresthesias, areflexia, paralysis, GI symptoms, and dysrhythmias. Next. So some of the causes are intra to extracellular shifts like beta blockers, potassium load, supplements, foods, and rhabdo, or a decrease in excretion. In renal failure, you will see hyperkalemia in patients who have missed dialysis, very common. Next. EKG changes, this is pretty classic, the peak T waves, a sine wave, bradycardia. It actually it can look like ventricular tachycardia, but the T waves in this are sharper and the rate is slower. Next. So labs, obviously, again, the same suspects. Also get a blood gas to determine the pH. You can get pseudo hyperkalemia for hemolysis, which is why sometimes you want to redraw the labs. Prolonged tourniquet application when the blood is being drawn, or severe polycythemia. Next. So the treatment. This is the mnemonic that I used: C, big K, and di. So calcium gluconate, bicarb, insulin, glucose, caluresis, albuterol, and dialysis. And I'll go over these individually. Next. So this stabilizes the myocardium. This does not actually lower the potassium. Initial dose would be 3 IV calcium gluconate over 10 minutes if it's peripheral, or 1 of calcium chloride over 10 minutes if you have central access. Calcium only lasts for so long, so you may have to repeat the dosing. So isotonic, not hypertonic bicarb like I talked about earlier. Dilution, which helps with the hyperkalemia. It shifts potassium into the cells and it promotes excretion by alkalosis. Has to be isotonic. Not hypertonic. The dose is 3 amps of bicarb, added to a liter of D5W. Only works for patients with metabolic acidosis. Next. Insulin shifts potassium into the cells, give them glucose. If the glucose is less than 250, don't give them glucose. So the dose is 5 units of insulin. It lasts for several hours, but you may need to redose. Check the glucose every hour. Next. Okay, so this is the treatment of caluresis. Basically, you want to fluid resuscitate if they're hypovolemic, and then give them furosemide or other diuretics to get rid of the potassium. Next. Oh, wait. This is taking longer than I thought. Okay. Shift potassium into cells with albuterol. This requires a lot. This is like 4 to 8 nebulized treatments. We can't even use nebulizers now in RED in the event because of Corona. It would have to be a continuous nebulizer. Next. So dialysis, if all else fails, or it's already an end-stage renal disease patient on chronic dialysis. Next. Key points, calcium gluconate and chloride is a must to stabilize the membrane, the cardiac membrane. It doesn't actually lower potassium. My mnemonic is C, big K, and die for hyperkalemia treatments. Missed dialysis is one of the most common conditions leading to hyperkalemia. Next, calcium. Normal calcium, these are the different, I guess, units. Here we go by 8.5 to 10.5. It's the most abundant mineral in the body. It's in bones and teeth and soft tissue. The standard units, 1 milliequivalent is equal to 2 milligrams per deciliter or 0.5 millimolars per liter. Next. There's 3 forms. One is the ionized form. That's the form that's active. Some is bound to protein and some is complexed with anions. Next. The decrease in albumin leads to a decrease in total calcium concentration, but it doesn't change the active portion. Alkalosis will lead to a decrease in ionized fraction. This has to do with albumin binding either proton or calcium. Next. So homeostasis, the slide is kind of busy, but basically just recall that vitamin D, parathyroid hormone, the calcium sensing receptor, and calcitonin all play a role in regulating calcium. So the role in the body, it's in the muscle and cardiac contraction and nerve conduction, cells, coagulations, and enzyme activation. So hypocalcemia. Lots of things can cause it. Diuretics, DeGeorge, rhabdo in the acute phase, hypomagnesemia, ethylene glycol poisoning, and pancreatitis are some of them. Next. Symptoms, neuromuscular excitation, so anxiety, paresthesias, muscle cramps. For cardiovascular, you can get hypotension and other arrhythmias. Some other symptoms are hyperpigmentation, rickets, dental hypoplasia. Some signs, hyperreflexia. Trousseau sign is at the top. You get a BP cuff is inflated above the systolic pressure and you'll see spasm. The bottom, spastic sign, you tap over the facial nerve and the corner of the mouth will twitch. So EKG changes, you will see a prolonged QTC. You may see some T-wave abnormalities that look like ischemia. So workup in labs, again, just get all the electrolytes and the blood gas. That's about it. Next. Treatment, symptomatic, prolonged QT. Contraindications, if they have, if it's hyperphosphatemia, you can precipitate calcium phosphate. If it's ethylene glycol poisoning, don't correct it because you get precipitation of calcium oxalate in the brain. For digoxin poisoning, you can potentiate the digitalis poisoning. So for treatment, if it's severe, give them IV calcium initially for a loading dose and then do a maintenance dose. You can also do oral calcium after you're transitioning from IV calcium. So key points, hypocalcemia is common among critically ill patients. In those patients, you actually don't necessarily need to replace it. Calcium should be monitored aggressively and replaced during massive blood transfusion because the citrate in the blood will bind to calcium and lower the levels. Calcium repletion is contraindicated in certain conditions, and hypomagnesemia may exacerbate hypocalcemia. Next. So we are very behind. Okay, hypercalcemia. Next. So it's relatively common, usually from malignancy. Next. Hyperparathyroidism is another really common cause. Next. It can happen from medications, things like thyrotoxicosis and granulomatous disease. Next. Symptoms, this is from Roche Review. This is a question bank for emergency medicine. It's really great. Bones, stones, groans, and psychiatric overtones is a mnemonic that we commonly hear. Next. So for EKG changes, you'll see depressed ST segments, widened T waves and QT intervals, and bradyarrhythmias. Next. There is, again, there's another equation worth mentioning. If the albumin is abnormal, you should correct the calcium level. Next. So treatment, basically, if it's normal saline, you can give them furosemide or calcitonin, but it's not necessary to start in the ED because it takes a while to start working. Next. You can do IV bisphosphonates, which again, not necessary to start in the ED, but it's first line for malignancy-associated hypercalcemia, dialysis if they're in renal failure, or steroids if they have granulomatous disease. Next. So what is a side effect of bisphosphonates? Yes, okay, great. Sorry, I'm in a rush. I didn't realize how long this would take. So yeah, jaw osteonecrosis is mentioned in the bottom on the right. That is a side effect. So some key points, basically, if they're hypercalcemic and symptomatic, replete their volume with normal saline.
Awesome. And just for time purposes, I will actually say these are going to come to you because we're going to actually give you all the PowerPoint slides.
Sorry, guys.
No worries. I was like, I don't want you to feel like you're rushed.
Okay. Well, the next two are pretty fast. So
Are they? I was like, I could do that.
So that's good. So normal magnesium, 1.7 to 2.2. I'm not going to read the numbers to you. It's the second most abundant intracellular cation. Most of it is excreted through the stool, some in the urine. Next. So magnesium is super important. It's in enzymes and nucleic acids. It has a role in coagulation, the cardiac potential. It's actually also a treatment in asthma and for eclampsia. So if magnesium is low. Multiple causes, all these things are listed in basically every cause of all the other electrolyte abnormalities. Next. Workup in labs, we're looking at the bottom two rows. So you'll see neuromuscular irritability, hypocalcemia, tetany, nystagmus, and seizures if the magnesium is really low. EKG, it's actually similar to the findings of hypokalemia and hypocalcemia because usually there's a concomitant issue with magnesium too. You'll see a prolonged QT. Usual labs, check electrolytes. So this is basically what I've been saying this entire time. If you have hypomagnesemia, the other electrolytes are probably out of whack as well. Next. It's generally safe to replace it, except in myasthenia gravis because of the increased risk of muscle weakness and renal failure because magnesium may accumulate. Next. For replacement, magnesium sulfate is most commonly used, a loading dose of 2 grams over 5 to 15 minutes, and then another 2 grams over 30 to 60. So key points, treat the other electrolyte derangements when repleting magnesium, monitor for areflexia, respiratory depression, hypotension, and arrhythmias. Next, hypermagnesemia. This really isn't an emergent issue, so we can rush through this a little more. Next. Some weakness, you can get muscle weakness, lethargy, confusion, nausea. Next. Again, same workup. If it's really bad and it's it's symptomatic, do 10 mLs of calcium chloride over 2 to 3 minutes. You can also give them IV furosemide. So, oh, that's fine. Next. Next. Okay. Ooh. Yeah. Okay. So, yeah. Okay. We'll do phosphate. Okay. Okay. So phosphate, if you recall, it's an ATP. It's everywhere. You really need this. It has a role with parathyroid hormone and in the kidneys. Next. So this is a good chart. We can go over it later. Next, hypophosphatemia. Next, fairly unusual. It's usually in critically ill patients. Again, the usual causes: alcoholism, drugs, etc. Next. So rhabdo is something that was mentioned earlier. Basically myoglobinuria damages the kidneys. You'll get high phosphate, high potassium, and low calcium. Next. Signs and symptoms, you have hematologic symptoms, neuromuscular symptoms, cardiac, and metabolic. Next. Again, check the electrolytes. So I don't need to read this whole thing to you, but basically just if you're replacing the phosphate, take into account if they're in renal failure or if the calcium level is abnormal because it can cause precipitation of other things. It's fairly uncommon. When hypophosphatemia is severe, it can have serious consequences. And I think that's it. No, okay, no, we have hypophosphatemia. JK. Just kidding. Got excited. Okay. So causes renal failure, hemolysis, excess vitamin D. Next. Yeah, I said that. Okay, again, electrolyte panel. You can do dialysis, phosphate binders. Obviously, don't give them vitamin D because that increases phosphate. Next. Okay, there we go. Okay, sorry that was really rushed, guys. I didn't realize it would take so long. I've never made that many slides before. But you know, feel free to ask Shelly if you have any questions for me if you review them later on.
That sounds good. No, thank you, Marielle. That was great. I didn't even you forget when you're working how many electrolytes there are and how many problems there can be because you already learned it. And then until you're teaching it and you're like, oh, that's a lot. Yeah.
Yeah.
So hopefully you guys enjoyed that. If you have any questions, feel free to message in the chat and either we will answer it now or we will email you answers later. Also, if anyone's on the call with Barney, he did mention to me if someone was interested in research to look into getting access to medical records because he goes, you need to know about medical records to know what you want to study in people, essentially. Okay, we got a question on a physical exam. How can we tell apart edema due to electro disturbances or endocrine disorders versus just higher fat distribution on body parts where it is harder to tell, like the face, for example? That's a great question. Hi, Marielle.
Fred emailed me. He's distracting. You're distracting me, Fred.
So yeah, they're saying, how can you tell the difference between the edema versus electrolyte disturbances or endocrine problems versus like fat distribution?
So for fat that's a good question. For edema or fat distribution, you're saying basically the patient will look bigger overall. With edema, for the most part, you can actually get if you press, it's really important to press because you'll see pitting for or if they have socks on, if you take them off, it will also look pitted. Whereas with fat, you can't really press it in, if that makes sense. I don't know if Shelly, if you want to add to that.
It doesn't. So if you put your thumb essentially and you just like rest it on their like leg, pretend this is their leg, and you press your thumb and then just let it go. Most people, you don't see an indent. When you have a crater, that's where it's like edema from like electrolyte things, like where it's like fluid out into the rest of the body.
Yes.
If it doesn't create that crater, then it's most likely something else. Usually like an endocrine disorder or other problems.
And the from endocrine disorders, you actually get generally a characteristic distribution of fat. Like you get the buffalo hump, which I know that's not a very nice term, but I can't think of the other term for it right now. The fat will be here, or you get the moon facies. With edema, it's usually in the legs.
Awesome. In trauma patients, how can we manage the fluids in what ratio, colloids versus crystalloids? So we usually start with a normal saline, at least in Morristown. We usually start up to 2 liters, and then we change to blood products. So it's a good point because like the reason it used to be old school where we just do fluids, but they had done studies that were actually diluting the blood in the patients and they're not actually oxygenating the rest of their body. So that's why now you start with crystalloids and then you move on to blood products as soon as you can for trauma patients. Do we have to know by heart all the appropriate doses for treatment? That's a really great question. No. I have told a lot of my interns before that it's not important to know exactly the dose. You could always look that up, but I do tell them to know emergent doses for things like in a code situation. So when someone's cardiac arresting, to know those doses, which we will be covering ALS and BLS tomorrow. So we'll talk about that a little bit more. And just knowing the rapid doses for like a calcium gluconate, just for a cardiac arrest, essentially, is what we really care about. But everything else, you could look it up, or you have your lovely pharmacist like Kelly the other day. She has helped me out a lot if I didn't know a dose. And anything else?